Hola, buenas tardes. Dando continuación con este ciclo de conferencias internacionales organizado por la Comisión de Endoscopía Flexible de la Asociación Argentina de Cirugía. En el día de hoy vamos a tratar sobre el tratamiento endoscópico del esófago de Barrett y del adenocarcinoma en esófago de Barrett, y contamos para estas dos conferencias con dos referentes internacionales de primer nivel, el doctor Jacques Bergman de Holanda y el doctor Eduardo Guimarães de Moura de Brasil. Van a coordinar estas conferencias los doctores Alejandro Nieponice, que es cirujano endoscopista de la Fundación Favaloro, y el doctor Matías Mihura, que es cirujano endoscopista del Hospital Británico y del Centro Gallego de Buenos Aires. Así que ambos son integrantes de la Comisión de Endoscopía Flexible, y los dejo con Alejandro para que podamos empezar este ciclo de conferencias. No sin antes agradecer a ambos participantes, a quienes realmente le agradecemos su participación, su presencia, el compartir con nosotros su experiencia y sobre todo el compartir su tiempo. Muchísimas gracias.
Bueno, muchas gracias, Sandra. Un placer empezar uno más de los webinars de la Comisión de Endoscopía Flexible, que vienen siendo bien asistidos y con grandes invitados, y hoy no es la excepción, porque la verdad es que contar tanto con Jacques y con Eduardo para tratar este tema es un enorme privilegio. Para no quitarles tiempo de la parte académica, vamos a pasar directamente a la primera conferencia. Yo le pedí al doctor Bergman que nos contara un poco sobre qué aprendimos en estos años sobre la ablación por radiofrecuencia, o en realidad la ablación del Barrett en general, que hace unos 10 años tuvo un pico de fama y veíamos en todos los congresos como el New Kid on the Block, y después se fue generalizando y apaciguando un poco, pero todos seguimos ablacionando aquellos pacientes que tienen riesgo de avanzar hacia el cáncer de esófago, y Jacques, sin dudas que fue el pionero, máximo referente en lo que tuvo que ver con la ablación del Barrett, y además sigue siendo el pionero en los nuevos paradigmas que va a haber sobre la ablación, y tenemos el orgullo de que creo que va a presentar por primera vez seguro en América Latina una de las nuevas tecnologías que tuvimos el gusto de ver hace poco juntos, y que él fue el primero en el mundo en hacerlo. Así que con esa presentación, Jacques es el jefe del AMC en gastroenterología, y creo que no necesita más presentación porque todo su currículum habla por él. Jacques, nuevamente, es un honor tenerte. Has estado en Argentina hace 2 años, y cuando termine la pandemia volveremos a invitarte en forma presencial. Hoy te tenemos en forma virtual y es un gusto escucharte.
Thank you, Alex, and I'm very happy to be a part of this symposium on my favorite topic, Barrett's esophagus. Actually, I'm pretty proud to be part of this esteemed panel, because with Argentina and Brazil are my 2 favorite countries if it comes to soccer play. Usually we have difficulty beating the Brazilians and the Argentinians. And today it's not about winning or beating, but still it feels a little bit awkward in being in Amsterdam. The last time that I spoke on this topic for an Argentinian audience was when I was in Buenos Aires, I think about 2 years ago. And I hope that this terrible COVID pandemic will way over, and that we will be able to attend meetings like we have been doing in the past in person in the near future. I'm going to speak to you about endoscopic management of Barrett's esophagus. Here are my disclosures. And this is a situation where we were about 10 years ago. Early neoplasia and Barrett's, low-grade dysplasia and high-grade dysplasia basically were not allowed to be treated endoscopically, only as part of clinical trials. And if a patient would be diagnosed with cancer, no matter if it would be an early cancer or a more advanced cancer, esophagectomy was just the standard of treatment. Now, over the course of the last decade, we have seen an organ preservation revolution in this field, in which now high-grade dysplasia and mucosal cancers are treated endoscopically. Low-grade dysplasia, provided that it's confirmed and reproduced, is a good indication for ablation therapy. And even a subgroup of patients with submucosal cancers, esophageal preservation may in fact be a realistic goal. Now, during this part of my lecture, I will be focusing on the accepted indications for endoscopic management of early Barrett's neoplasia. And the approach is usually a two-step treatment in which the endoscopic resection is the mainstay. We cut away the visible lesion, wait for the pathologist to give us the green light, and only if we know that we actually can curatively treat the patient, and that depends on the pathology result of this lesion, only then we will do an additional ablation, generally with radiofrequency ablation, for a complete removal of the residual Barrett segment. So the treatment strategy is endoscopic resection of a visible lesion, and then every 3 months, usually we start off with a circumferential ablation, and then every 3 months we continue to do these ablations until the whole Barrett segment endoscopically is completely gone, and then we enter the patient into endoscopic follow-up. Now, at some point, if we fail and if there's residual Barrett's, we do not necessarily have to continue with the ablation. Sometimes it's just wiser to do an endoscopic resection as an escape treatment. You can hardly call that an escape for a failed treatment, because endoscopic resection is also the starting point. So it's a combination therapy of endoscopic resection for diagnosis and sometimes an endoscopic resection for a final patch-up. So here's an example of a patient that I treated more than 10 years ago, 8-centimeter Barrett's with an early cancer here and here. And there was also a small visible lesion here that we resected with EMR. Then treated him with radiofrequency ablation, and most of his proximal part of his Barrett's nicely converted into squamous. Here you can just see the scarring of the previous endoscopic resection, but below this relative stenosis, there's still a significant residual Barrett segment left that we then resected endoscopically by EMR in 2 sessions for a complete removal of this 8-centimeter Barrett segment. This is more than 10 years ago, and these images are identical to the images we obtained 6 months ago in this patient. So the endoscopic resection technique for most early lesions in Barrett is the multiband mucosectomy technique, in which basically a varicella-like gating device has been changed in such a way that this snare can be passed alongside the wires that are used to release the rubber bands. Now you're not ligating varix, but you're ligating a small visible lesion that you then suck in the cap without the need of submucosal lifting. You release the rubber band, and then you use the snare to resect that lesion. We've done a large-scale retrospective study on over 3,500 MBM procedures, in which the vast majority of those endoscopic resections resulted in a complete endoscopic resection, and perforation and delayed bleeding were quite rare. There's a new device recently on the market by Boston Scientific, in which the bands have been moved backwards so that there is a better endoscopic view through the cap compared to the duet, in which the black bands really take away a significant part of the light, and also the wires and the space that you have alongside the wires to pass your snares or coagulation devices down is slightly optimized with this newer device. We ran a multi-center study on the use of this device, and basically the results were identical to what we knew from the previous multiband mucosectomy device. Complete resections in virtually all cases, and perforation and bleeding occurring in less than 1% of patients. Now, what about ESD? Eduardo is going to go more into that in his lecture after mine. From my perspective, ESD in Barrett's is significantly more complicated than it, for instance, is in the rectum or in the stomach. And especially since EMR and RFA are so much easier and so effective and safe, it's difficult to justify doing an ESD for all early Barrett's lesions. So we use it selectively. Our ESD rate has gradually gone up over the last 5 years, and I think we're now at about 40% of all the endoscopic resections we do with ESD, but it's an imperative technique to use if the lesion is as bulky as this or suspicious of submucosal invasion, because the only way to get a lesion like this completely out, you can't do that with a cap-based technique. You really need an ESD for a complete resection of those bulky lesions. Now, with this selective use of ESD, we've looked at all the ESDs we've performed in the Netherlands over the last 8 years for early Barrett's cancer. The indications, as I said, selective, so bulky lesions that have a large intraluminal component, which would immediately fill the cap if you would try to resect it with a cap technique, so you would never be able to cut down at the base of the lesion. They were 30% of the indications, and the remaining patients all had lesions that were suspicious of submucosal invasion, and in which we wanted to optimize the pathology specimen for histological assessment. Now, in my country, endoscopic treatment in Barrett's is centralized, and even more centralized for ESD. Only 4 of the 9 treatment centers in my country do ESD. The average amount of time that we spend on this is about 5-fold that we use for endoscopic mucosal resections, and the complication rates in expert hands are quite acceptable. A perforation rate, which is generally small and can be managed endoscopically because usually they are recognized immediately during the procedure, and a delayed bleeding rate or a stricture rate basically related to the extent of the resection that you do. Now, with ESD being used selectively for these more ugly lesions, one of the things we find is that in the resection specimen of lesions like this, about 50% of the resection specimens have a positive vertical resection margin, which should suggest that there may be tumor cells left behind. And the automatic action we are used to take upon a vertical R1 resection is to send these patients all for an esophagectomy. But that may not be a necessary thing to do in all patients. And so I would, showing you this slide to suggest that you're careful in drawing very firm conclusions if you do an ESD and you do find an R1 resection, because in the 34 patients that we had in our cohort, when we did a post-ESD endoscopy, and generally we do that after 6 to 9 weeks, persistent neoplasia was only discovered in 30% of those, and they were sent to surgery. But in 70%, we didn't find any residual neoplasia in the scar of the ESD, and then either after surgery or after endoscopic follow-up, these patients did not manifest any local recurrence. So an R1 resection after an ESD in Barrett's may not be an absolute indication, and maybe it's just wiser to wait and see for a couple of months, because lesions like this with residual cancer generally then invade into the deeper muscle layer and may even require chemoradiotherapy and not just esophagectomy. And a subgroup of patients may actually benefit from a wait and see policy and not automatically sending them to surgery. But back to the standard technology, multiband mucosectomy and RFA are the very effective standard approach that we have for our patients in Europe. Here is a paper that we published in Gut, in which we had 13 leading centers in Europe, all experienced in endoscopic resection and all adequately trained in RFA, treated 132 patients with high-grade dysplasia and cancer, eradicated the neoplasia in virtually all, were able to achieve complete eradication of the Barrett segment, so endoscopically complete conversion to squamous, not a single biopsy with a single goblet cell in the vast majority of patients, and then during follow-up, actually persistent remission of neoplasia in most patients, and recurrence of Barrett's actually being quite rare. So with these excellent results for high-grade dysplasia and early cancer, the question then came up, how about low-grade dysplasia? Now the issue is that there's a wide variability in studies showing the cancer risk for low-grade dysplasia, and the general idea is that the cancer risk is said to be low and that these low-grade dysplasia patients have less to gain and more to lose than the patients that are more on the right-hand side of the spectrum. And therefore, you should not be treating low-grade dysplasia outside clinical trials. Well, the issue all relates to how reliable is this diagnosis of low-grade dysplasia. And in my country, if it's diagnosed by community hospitals, we have had 146 patients. When that is reviewed by expert pathologists, we actually find that a significant part of those that are said to have low-grade dysplasia, upon review by an expert pathologist, are downstaged to non-dysplastic Barrett's. And only a small subgroup, actually low-grade dysplasia, is confirmed. Now, in this study that we published in 2010, we had a significant time of follow-up after this baseline supposedly low-grade dysplasia diagnosis. And therefore we could see what happened in these 51 months follow-up in these patients. And the patients that were downstaged to non-dysplastic Barrett's actually had a very low progression rate. 0.49% is basically the progression rate you would expect from non-dysplastic Barrett's, and suggesting that these 110 patients were rightfully downstaged to a lower risk diagnosis. However, the 15% of patients in which the diagnosis was confirmed really had a scary progression rate, about 13% per patient year. So that made us create this one-liner: low-grade dysplasia in Barrett's is generally overdiagnosed, because the majority is not low-grade, it's actually non-dysplastic Barrett's. But it's also underestimated because these dilute these, so that you underestimate the true risk of low-grade dysplasia if you look at the original cohort. But confirmed low-grade dysplasia may therefore be quite an ugly disease. As I said, this was published in 2010, so we repeated that in a new cohort of patients, in this case over 250, again an expert panel looking at it, same results. 60% now downstage to non-dysplastic with a low progression rate. In this case, 30% confirmed low-grade dysplasia, and again, almost a 10% per patient year risk of progressing to high-grade dysplasia or cancer. Now with a progression risk of like this, it may be justified to do a prophylactic radiofrequency ablation. So that's what we did in this randomized controlled trial that we published in JAMA. We randomized patients to either radiofrequency ablation or surveillance. But we only randomized patients if their diagnosis of low-grade dysplasia was confirmed by an expert pathologist. So these are 126 patients with confirmed low-grade dysplasia. And then you can see that after RFA, the progression rate is low, whereas surveillance shows the same thing that I've shown you in the previous slides, about a 10% progression rate for every year the patient is in follow-up. And this was highly statistically significant. Actually, we had to close down the study early because of these significant results. And if you only look at cancer, still the results were statistically significant. Now, this was published in 2014, and we had 3 years follow-up at that time. We've extended the follow-up recently. We published that in GIE last year. Therefore, we could add an additional 40 months to these two cohorts. And in the RFA arm, we had no additional progressors. But in the surveillance arm, of the 50 patients who had not progressed at the time we closed the randomized trial, we had 5 additional progressors whereas 15% were selected to undergo RFA based on the results of the original study. So we basically eliminated the high-risk patients and still had 5 patients that had progression. So these results really suggest that a confirmed diagnosis of low-grade dysplasia in Barrett's is a disease with a significant progression risk over time. And that for these patients, actually prophylactic treatment with RFA is justified, provided that you've done something to confirm your community pathologist diagnosis, and ideally if that diagnosis is reproduced at a second endoscopy, because that logically strengthens that diagnosis even more. Now then, what's the long-term outcomes after RFA? And we published the results of this study in Gut last month. And these are the results of all patients treated in my country over the last 15 years. All endoscopic resections and all ablations in Barrett's in the Netherlands are performed in one of these 9 Barrett expert centers. And the endoscopists and the pathologists in these centers have been very rigorously trained in joint training programs. And since 2008, the centers are using the same treatment protocol. We have 3 to 4 meetings a year, sometimes with the endoscopists and pathologists, but also standalone meetings with the pathologist looking at slides of resection specimens and biopsies. And each of these centers sees at least 10 new high-grade dysplasia or cancer cases per year. Excuse me. So there's over 1,100 patients in this study. The average patient spectrum, as you know, most of them male, 65 years at the time of treatment, with a median Barrett's of C2 and 4, about a third treated for low grade, the remaining 75% treated for high grade dysplasia or cancer, and most of them actually requiring an endoscopic resection. All patients with early cancer had an endoscopic resection because early cancer without a visible lesion is something that you should not accept as a diagnosis. We needed a median of 2 RFA sessions. I would say my impression is that we at least do 1 circumferential RFA and 2 focal RFA in our patients. And then once we had complete removal of the whole Barrett's, these patients really had significant follow-up. So a median of 4 months and a median of 4 endoscopies, but more importantly, a significant number of patients with really prolonged follow-up, more than 5 years and 370, and over 100 patients with more than 8 years follow-up, and very, very few patients lost to follow-up. So this is the ideal long-term follow-up that you have for centralized treatment of early Barrett's neoplasia with endoscopic resection and RFA. And the long-term results were really very reassuring. A diagnosis of low-grade or high-grade or cancer at a rate of 0.8% per year. If you only looked at high-grade or cancer, 0.6% per year. And the severity of these recurrent lesions was actually quite mild. A quarter of our so-called recurrences had a normal appearing neo-Z line with biopsy showing low-grade dysplasia, but none of these patients progressed during a median follow-up of 4 years. And you may question if a quarter of these recurrences actually have any clinical relevance. The larger part of the recurrences were patients with high-grade dysplasia or early cancer, or recurrent Barrett's with flat low-grade dysplasia. But all these patients were detected at an endoscopically curable stage and cured by endoscopic retreatment. So here is an example of a patient at baseline, long segment Barrett's. Here's a visible lesion that you should resect and should not ablate. Here's the endoscopic resection, and then 3 months later, the radiofrequency ablation, and after 1 or 2 additional treatments, a complete conversion to normal appearing squamous mucosa. And then this is the recurrence, actually one of the more uglier recurrences we've seen, a significant extent of a lesion that upon endoscopic resection showed intramucosal cancer, and then after 3 years still is in complete remission. Now, these are the worst outcomes we had in this cohort. We had 5 patients who then during follow-up progressed to an advanced cancer, which is 0.4% of the total cohort. 2 of them still underwent curative surgery and are more than 4 years out without any signs of recurrent disease, but we had 3 patients that died of metastasized disease. We are publishing all these adverse outcomes. So the worst cases, for instance, all these 5 cases, we are publishing them as case reports on our website, and the address of the website I will show you at the end of my lecture. And what we've seen is actually these were really all patients that at baseline didn't fit in any of our study protocols that we had ongoing at that time. So these patients had very long Barrett segment, really severe reflux disease that was poorly controlled, had multifocal cancers, required multiple endoscopic resections. So really a sub-selection, in my opinion, beyond what you would call the average patient that should undergo endoscopic treatment. So I think it's fair to say that endoscopic resection with RFA is highly effective in a centralized setting. Now, a couple of slides on new trends in ablation. This is the switch that Medtronic made from the original standardized diameter balloons. There were 4 different diameter balloons that they had initially, and they switched to this single halo express balloon that accommodates itself to the diameter of the esophagus, and then upon desufflation rolls back on itself for additional ablations further down the esophagus if you need. Now, we did a randomized trial with this new balloon because we were not sure what the optimal ablation regimen should be. The original standard approach would be to do an ablation, then remove the catheter, clean the catheter, and clean the ablation zone, and then reintroduce the catheter for a second ablation pass. So ablate, clean, and ablate. Now, with the fixed diameter RFA balloons, we had shown that actually a much simpler approach, just do a double ablation at the same level and no cleaning, worked just as good. So you inflate your balloon, you ablate, the balloon rolls back on itself, immediately inflate the balloon and ablate the same zone for the second time, and then move down and do a double hit at the second level. And we did an arm with a single ablation and no cleaning at all. And what we found was that we actually had to close down this simple double technique. So doing an ablation, a double ablation at the same level, an ablation regime that we were used to apply when we had the fixed diameter balloons, with this expanding balloon resulted in 1 out of 5 of these patients having a severe stenosis. And these were the ugliest stenosis I've ever seen after circumferential RFA. They required at least 6 dilatations and had really a poor efficacy outcome in the end. So logically, it was decided to stop enrollment in this arm, and then we were left with the standard approach, so ablate, clean, ablate, or just a single ablation. And then at 3-month follow-up, we actually found that this single ablation really was less effective than the ablate, clean, ablate approach. So that brings us back to that with this new Halo Express balloon, we really have to stick to the old-fashioned ablate, clean everything, and ablate again to avoid too much energy being transmitted to the esophagus if you do a double hit at the same time. Now, this is hybrid APC. The study is under review with, I think, GUT at this point, and this is a APC probe that allows you to inject through the APC probe of saline, which lifts logically the mucosa off the deeper wall layers, and then immediately after the lifting, you can then ablate the overlying mucosa without the danger of actually deeper damage to the muscularis propria. It looks easy, and it is in even in expert hands slightly more complicated, but a multi-center European study, as I mentioned, is close to being published, and the results are actually pretty good. Now, this is cryoablation, cryoballoon ablation, in which liquid nitrogen oxide is actually sprayed through a transfuser in a balloon to freeze up a segment of the Barrett's esophagus. Here we've done a 90-degree segment that we've frozen over a length of 3 centimeters, and then we apply a second 90-degree segment, and this is how it looks after you deflate the balloon. The superior part of the esophagus is still frozen and logically will gradually thaw and then become slightly swollen for an ablative effect. Here's a typical patient in our studies. Bas Weuste, my colleague in Utrecht, is the one who's leading the cryoballoon ablation studies in Europe. And this is one of the patients in that study in which we selected to treat only 180 degrees of the Barrett segment. That was just part of the study. And this is the effect of the ablation. You can see the corresponding tongues that we've not treated still being intact. And this area, only a very small residual Barrett's island of this much larger tongue that we ablated. And this is something really very new. It's called steam ablation, in which a through-the-scope device is supposed to seal off a segment of Barrett's. And then within this chamber that you create by these 2 umbrellas, you ablate the tissue by just adding steam. It's a non-contact technology that ideally should result in effective ablation. Now, it's not yet tested in humans in this setup, as I've shown you on this animation. We've done the first studies in humans using a cap-based approach with this small catheter, just to do a very localized steam ablation of a small area in the Barrett segment, just to see if this actually works. Here is an example of a patient in our study in which we chose to ablate these proximal tongues. This is then how it looks immediately after the ablation. And this is then how it looks after 6 weeks. This is the corresponding area that we have ablated. We also ablated these 3 areas, and they correspond with these 3 months later. In all fairness, this hybrid APC or cryoballoon ablation and steam ablation, much of the interest in this new technology is because it's new and because there's money to be made with technology like this. I'm not sure where these 3 ablation technologies will find their place. For hybrid APC, we only had a single multi-center European study, which was finished more than 5 years ago and is now close to being published. I've done about 15 patients in that study. In my hands, I just find it too cumbersome and too much operator dependent, too much depending on what I decide to treat, for which I would not be sure if somebody else would do an identical treatment, whereas if I would be doing an RFA in that patient, the treatment is much more reproducible amongst different endoscopists. To me, it makes no sense to treat a 10 centimeter Barrett's with an approach like this, where I can do that in 15 minutes with RFA. I'll probably be spending 3 times as much time on that patient with hybrid APC. For cryoballoon ablation, there are some theoretical advantages maybe of cryoablation, maybe because it causes slightly less post-procedural pain, although I've never considered that to be a major disadvantage of RFA, but studies actually show that cryoballoon ablation causes less post-procedural discomfort to patients. There's a variety of devices still honor investigation. There's a 90-degree and 180-degree and even a 360-degree ablation tool coming up. There's 2 multi-center cohort studies initiated, one running in Europe, as I said, led by Bas Weusten. And steam ablation is nice from a theoretical concept, but we've not moved beyond feasibility studies there. And we really have to see where these 3 technologies find their place. So back to basis, I think the standard multiband mucosectomy technique for most of your early cancers and high-grade dysplasias suffices as an endoscopic resection technique. And ESD should be used selectively. And RFA is by far superior to any other ablation technique available for Barrett's. And I think this combination treatment should be the treatment of choice still. Now, if you want to learn a little bit more about the different steps, about how do you image a Barrett segment and how do you avoid that you ablate visible lesions, there's a great, this website really has a beautiful training tools for that. It has training tools for imaging. It has nice presentations on ESD and endoscopic resection and the different ablation tools, and also has significant information for your pathologists. So if you're interested in treating early Barrett's neoplasia, just spend some time on this website. It's free, and I think it has some good training and teaching materials there. I will stop here and I will gladly answer any of your questions. Thank you very much for your attention.
Jacques, impresionante, impresionante. Muchísimas gracias. Como siempre, tus charlas son a tope de lo que se puede encontrar en la ciencia en el Barrett, y es un placer escucharte cada vez, aunque conozco un montón de lo que has hecho, pero siempre lográs sorprenderme con nueva información y con información seria, que es lo que más se necesita en el mundo de la ciencia para tomar decisiones. Cuando termine la charla de Eduardo, vamos a hacer algunas preguntas. Si tenés un ratito más para estar con nosotros y hacemos algunas preguntas y respuestas.
Bueno, gracias. Un placer, Jacques. Muy linda la charla. Muchísimas gracias por compartir tus conocimientos con nosotros. Y bueno, tengo el placer de presentar a Eduardo de Moura, a quien le agradezco en nombre de toda la comisión de estar hoy con nosotros también, como dijo Alejandro. Eduardo de Moura es el profesor del Departamento de Gastroenterología y el director del Servicio de Endoscopía de la Universidad de San Pablo en Brasil. Y bueno, nuevamente un placer y muchísimas gracias, Eduardo.
Gracias, amigo, por la introducción. Gracias por la invitación. Vamos a hablar un poco de la experiencia que tenemos, que es mucho menos de la importancia de la experiencia de Jacques, pero vamos a demostrar a usted cómo nosotros acá decidimos por la conducta en el esófago de Barrett. Cada vez más tenemos experiencia porque hay un incremento del número de personas con esófago de Barrett, con displasia en nuestro medio, porque tenemos muchas personas que ahora están en la fase de obesidad. En Brasil, 60% de la población está con el peso acima del ideal y 15% son obesos mórbidos. Entonces, tiene una gran cantidad de personas que ahora están a evoluir con complicaciones del reflujo, el esófago de Barrett y la displasia. ¿Qué pasa? Aquí. La resección endoscópica se ha convertido en el tratamiento de primera línea para el tratamiento de las neoplasias superficiales en todo el trato gastrointestinal. La resección endoscópica de la mucosa y la disección endoscópica de la submucosa son técnicas establecidas pero distintas para el tratamiento de la neoplasia gastrointestinal superficial. Y vamos a ver cómo en Barrett se puede confluir la idea del tratamiento con ambas técnicas, ¿no? Si vamos a hablar de la resección endoscópica radical escalonada, que es una técnica en la que el segmento del esófago de Barrett complejo se elimina en sesiones consecutivas en lo mismo tiempo. Se puede hacer por distintas técnicas. Acá la utilización de banda seguido de la resección con la arsa. Es la técnica mucho más frecuentemente empregada. Muchas veces se restringe a área de neoplasia o la área específica del adenocarcinoma, pero muchas veces lo endoscopista tiene la idea de sacar a todo lo tejido. Entonces se hace una resección radical. Y otros más a personas que tienen más de un foco de displasia y que se hace necesario hacer la ablación. Entonces, a principio, empezamos con la técnica de mucosectomía, como aquí ha demostrado, pero después, ahora que tenemos la radiofrecuencia, en muchas situaciones hacemos la asociación de técnicas. Y vamos a hablar un poco de esto un poco más adelante, ¿no? Cuando nosotros vamos ver un estudio que fue publicado por el grupo de Jacques, mira que acá tiene muchas complicaciones cuando usted va a evaluar. Se saca toda la Barrett con la arsa en una única sesión, múltiplos fragmentos, o si usted va a hacer la resección específica del área de displasia y que se complementa con la radiofrecuencia. Mira que con la radiofrecuencia agregada o una resección específica de la área, usted tiene mucho menos complicaciones y el resultado a largo plazo es muy adecuado, principalmente las personas que tienen un Barrett con menos de 5 centímetros. Entonces, ¿qué sabe ya sobre este tema? La resección endoscópica radical escalonada es segura y eficaz para la neoplasia de Barrett temprana, pero está asociada con las estenoses esofágicas. La resección endoscópica focal, seguida de ablación pela radiofrecuencia, es segura y eficaz para la neoplasia de Barrett temprano, pero no proporciona una muestra completa para la evolución histológica. Y esto es un problema que vamos a hablar un poquito más también adelante. ¿Cuáles son los nuevos hallazgos demostrados en ese estudio? Que la resección endoscópica radical escalonada resultou em uma maior taxa de estenose do esôfago em comparação com a resecção endoscópica focal, seguida da radiofrequência, e requeriu um maior número total de sessões terapêuticas, devido a sessões de dilatação para tratar as estenoses esofágicas. E como pode impactar em la prática clínica e no futuro previsível? Para os pacientes com neoplasia de Barrett temprana, se pode preferir uma abordagem endoscópica combinada, de resecção endoscópica focal, seguida da radiofrequência, em relação à resecção endoscópica radical escalonada. Há dois argumentos adicionais a favor de uma estratégia de la resecção endoscópica focal, seguida da radiofrequência, em lugar de la resecção endoscópica radical escalonada para a eliminação complexa do esôfago de Barrett. Primeiro, foram estudados só aqueles pacientes com Barrett que tinham uma dimensão menor que 5 centímetros. Se hubiéramos estudado segmentos mais largos, é possível que o grupo de la resecção escalonada hubiera encontrado mais complicações e fracassos. Por el contrário, Herrero ha publicado e ha demonstrado que a radiofrequência também é eficaz e seguro no segmento de esôfago de Barrett mais largo, incluindo as pessoas com Barrett com mais de 10 centímetros. Em segundo lugar, o tratamento combinado da resecção endoscópica focal e da radiofrequência é tecnicamente menos exigente que a resecção endoscópica radical escalonada. Então, agora temos o primeiro ponto. O primeiro ponto é que a mucosectomia, a princípio, se deve fazer de maneira focal e não se fazer escalonada, porque quando você utiliza a radiofrequência para complementar este tratamento, você terá muito menos recorrência, muito menos complicações. E a taxa de recorrência não há diferença. Portanto, se tenho a mesma taxa de recorrência e tenho muito mais complicações, como principalmente a estenose, é muito melhor a princípio que temos a ideia de fazer a resecção endoscópica focal, a mucosectomia, e complementar com a radiofrequência. Este é o ponto que vamos depois discutir com a dissecção endoscópica da submucosa. Entonces tenemos lo primero concepto acá, que para nós ahora é melhor tratar focalmente la displasia ou o adenocarcinoma. La disección endoscópica submucosal es una técnica en la que el segmento de esófago de Barrett completo se elimina en una única sesión. La disección endoscópica de la submucosa es una técnica emergente asociada a una resección en bloque más alta y tasas de recurrencia más bajas en comparación con la mucosectomía. Esto es el punto. Ahora tenemos que discutir cuál es la mejor situación para tratar al paciente. La mejor situación para tratar al paciente es ofrecer al paciente una resección en pieza única para que el patólogo tenga toda la posibilidad de evaluar las márgenes horizontales y vertical para tener la idea si tiene riesgo de una recurrencia local o no. Esto es el punto. Lo punto no es si la mucosectomía o si lo ESG se competen. No. En verdad, si usted tiene una lesión que es posible sacar por mucosectomía en la única pieza, está muy bien. Empieza con la mucosectomía. Pero si tienes una lesión más amplia, tiene que tener la idea que la disección endoscópica de la submucosa puede ser la mejor opción. Pero en todos los casos de Barrett tiene esta aplicación, no es verdad, porque muchas veces tenemos esófago de Barrett de largo, con 10 centímetros, que usted tiene áreas multifocales, y esto hace con que tenga complicaciones de esta técnica. Y es por eso que tiene que evaluar los resultados que la literatura tiene sobre la mucosectomía y sobre la ISG, sobre la recurrencia. Mira que si vamos a evaluar este trabajo de Comeda de 2014, envolveu una revisión con 16 estudios, la tasa de recurrencia con la mucosectomía es de 2,6%. Y con la disección endoscópica de la submucosa es de 0,7%. Y es significativo. Por tanto, tiene mucho menos recurrencias locales con lo ISG do que con la mucosectomía. Pero la hemorragia tardía, la perforación y la estenosis tienen la misma tasa de complicación. No hay diferencia. El tiempo de procedimiento es mucho más rápido cuando usted hace la mucosectomía. E o que passa em lo acompanhamento tardio? No acompanhamento tardio não há diferença a respeito da recorrência, porque em la mucosectomia é possível que você faça outras resecções endoscópicas. Então, todos os casos nesses estudos que tinha recorrência depois da mucosectomia foram tratados com resecção endoscópica complementar. Entonces, si vamos a pensar a largo plazo, no habrá diferencia de la recurrencia, porque es posible sacar la lesión complementar cuando se hace la mucosectomía y tiene compromiso de la margen. Esto es un concepto que muchas personas no lo creen y que imaginan que la indicación no es la misma, porque usted va a tratar personas que tienen un Barrett pequeño e que provavelmente a possibilidade de estenose é muito baixa, e você vai tratar lesões muito mais amplas, em que a resecção da capa mucosa é muito mais ampla, e por isso tem muito mais risco de complicações. Então, a mesma patologia não se manifesta com as mesmas características. E que passa quando nós vamos avaliar a questão da incertidumbre patológica en la neoplasia asociada a Barrett? Mira que neste estudio de 31 casos de la mucosectomía y 20 casos de la disección endoscópica de la submucosa, la disección endoscópica produziu más resecciones R0 y más resecciones en bloque cuando se compara con la mucosectomía tradicional. Pero la mucosectomía tiene producto, márgenes laterales más equívocos, porque mira que usted tiene 41.9% de compromiso de las márgenes laterales contra 5% de la disección endoscópica submucosal. Esto ocurre tanto en las margens laterales como verticales. Entonces, esto es un punto que favorece la disección endoscópica de la submucosa. Este condujo a una capacidad para llegar a un diagnóstico definitivo en muestras de patología en 13 de 31 personas que ha hecho la mucosectomía frente a ninguna persona que ha hecho 20 disecciones endoscópicas. De las 13 muestras en este estudio de la mucosectomía con patología equivocada, se observó que 11 tenían al menos adenocarcinoma intramucosa. 4 de 11 pacientes optaram por submeter-se a uma esofagectomia eletiva, que a patologia quirúrgica final demonstrou uma enfermidade T1A e T1B. Então, a conclusão é que se compara a dissecção com a mucosectomia se associou com uma maior incertidumbre patológica na neoplasia associada a Barrett. Isto é uma verdade absoluta? Não, tem um número muito pequeno de pessoas que é submetido aos dois pacientes. Isto não é um estudo randômico, isto é apenas um estudo de corte, portanto, tem que avaliar as respostas com uma certa tranquilidade. Então, temos que ter outros critérios para compreender como vai se tratar estas pessoas. E, para tanto, há um estudo randomizado, é um único trial, que há uma comparação de uma dissecção endoscópica da submucosa versus a mucosectomia em las pessoas que têm uma neoplasia precoce em Barrett. Mira que quando você vai avaliar a completa ressecção em displasia de alto grado com o adenocarcinoma, a possibilidade de tratamento definitivo com o ISD é superior da mucosectomia. E quando você vai avaliar a ressecção incompleta de alto grado com o adenocarcinoma, também se tem muito menos ressecção incompleta na dissecção endoscópica da submucosa que a mucosectomia. Então, acá tem um ponto que é o ponto de que, a princípio, como resultado imediato, o ISD é superior à mucosectomia. O que passa depois de 30 dias, quando você vai reavaliar estas pessoas e vai observar o que passou com a ressecção inicial? Mira que não há diferença sobre a remissão completa da neoplasia. Acá tem que, depois da ressecção inicial e do tratamento da neoplasia residual, não há diferença se você faz a mucosectomia ou do OSD. Isto é um ponto que sempre me pergunto, por que depois de 30 dias são os mesmos, se eu tenho a documentação de que a mucosectomia inicial tem mais compromisso? É porque foi possível sacar mais fragmentos com outras técnicas mais de mucosectomia, e ao final você tem um patólogo muito mais fragmentos. Isto é um problema, porque sabemos que quando você tem mais do que 2 a 3 fragmentos de uma lesão, a taxa de recorrência local é de 15%. Então, sempre temos o conceito de que temos que sacar todo em peça única. Pero em Barrett passa algo distinto, porque em Barrett temos diferenças sobre do tamanho da lesão, se é largo ou não, e também da característica do envolvimento circunferencial, do processo inflamatório que está agregado, da possibilidade de ter áreas que têm infiltração da capa submucosa que não ha sido detectado no momento da dissecção. Há muitos fatores que interferem com este grupo de análise. O que tem de muito claro é que os pacientes com esôfago de Barrett, com uma lesão focal de neoplasia intraepitelial de alto grado ou adenocarcinoma temprano, menor que 3 centímetros, foram muito melhor tratados a princípio por la dissecção endoscópica da submucosa, pero em lo follow-up os resultados foram os mesmos. Então, como que vamos interpretar isso? Tanto a dissecção como a mucosectomia são altamente efetivas para ter a resecção endoscópica completa da neoplasia temprana no esófago de Barrett. Em comparação com a mucosectomia, o ISD requer mais tempo e o risco de eventos adversos graves que pode ser maior. Por outro lado, a dissecção endoscópica da submucosa logra com maior frequência a resecção em bloco, R0, e curativa. Sin embargo, em correspondência com os resultados de los ensaios não controlados, esta ventaja não parece ter um impacto sobre a necessidade de cirurgia eletiva e as taxas de resecção complexa por neoplasia. No estudio não pode excluir que a resecção em bloco por ISD pueda reduzir o risco de perder detalhes histológicos importantes em casos selecionados de estadios tumorales mais avançados em comparação com a mucosectomia por etapas. A neoplasia recorrente ou metacrônica é rara depois do ISD e da mucosectomia. Sempre que hace a radiofrequência, se realiza para a erradicação do epitélio de Barrett no neoplásico residual. É por isso que se previne as lesões metacrônicas. O risco de formação de estenose depois do ISD parece ser baixo em geral, porque nem sempre você hace a dissecção circunferencial. Você pode, como demonstramos no último caso que é demonstrado, hecho por nós, que sacamos solamente a área tumoral com margem de segurança. Então, isto é muito importante, porque a grande maioria das lesões são focales e envolvem menos que 50% da circunferência esofágica. Então, não é verdade a grande quantidade de pessoas que têm estenose. Depende de que paciente você está tratando e da característica que tem. Em vista de los excelentes resultados similares neste estudo, que é um estudo randomizado, embora envolva um número muito pequeno de pessoas, não? Solamente 40 pessoas, 20 pessoas em cada grupo, isso é muito mais um estudo fase 2 do que um estudo fase 3, embora randômico, isso é um estudo fase 2B, e que mostra que é seguro e que nos dá um caminho a respeito da efetividade, mas não nos dá toda a resposta, mas isso é um caminho. Portanto, em vista dos excelentes resultados similares depois do ISD e da mucosectomia em la neoplasia temprana no esófago de Barrett, este ensaio, em séries recentes não controladas, parece muito pouco provável que incluem os ensaios a grande escala muestras diferenças significativas em los parâmetros resultados clínicos em ambos os métodos. Portanto, me parece que os dois métodos são muito similares em relação ao resultado. O que se sabe sobre o tema hasta agora? Me vou repetir algo que falei há pouco, porque creio que temos que firmar o conceito de que as técnicas elas não são concorrentes, as técnicas elas são avaliadas caso a caso. E, para tanto, tem que sempre ter em mente que a ressecção endoscópica da mucosa é segura e eficaz para a erradicação da neoplasia de Barrett temprana. A incidência de recorrência se pode reduzir substancialmente mediante o uso combinado da ablação por radiofrequência. A dissecção endoscópica submucosa logra taxas mais altas de ressecções histologicamente complexas que a mucosectomia para a erradicação do câncer gástrico temprano e do câncer de células escamosas do esôfago. Sem embargo, tecnicamente é mais exigente e pode provocar mais eventos adversos, como falamos, na dependência de um compromisso de mais de 50% da circunferência do esôfago. Pero alguns ensaios não controlados sobre o ISD para o tratamento da neoplasia de Barrett temprana mostraram resultados prometedores, pero a relevância clínica, que é a taxa de recidiva local, ou mesmo a taxa de tumor, segue sendo incerta, justo porque você pode complementar o procedimento que é hecho por la mucosectomia. E quais são os novos hallazgos? Tanto o ISD como a mucosectomia são muito eficazes para a erradicação endoscópica da neoplasia em Barrett. O ISD tem esta resecção tecnicamente muito mais compleja, más alta, pero requiere más tiempo, requiere un treinamento muy afinado por lo endoscopista, y es posible tener un poco más de eventos adversos. Y a pesar de las vantagens técnicas iniciales, o ISD no parece ofrecer vantagens clínicas sobre la mucosectomía a largo plazo. E como pode impactar em la prática clínica e no futuro previsível? A técnica de ISD deve perfeccionar-se aún mais para acelerar o procedimento e aumentar a segurança. Sua aplicação deve limitar-se no momento a centros especializados, porque necessita de um aprendizado, uma curva de aprendizado muito maior do que uma simples mucosectomia. Pero o ISD deve avaliar mais a fundo as etapas localmente mais avançadas do adenocarcinoma de Barrett. Se você tem uma lesão, que você suspeita que há uma invasão superficial da submucosa, é muito mais adequado que você faça a ISD do que faça a mucosectomia, porque necessita fazer uma dissecção muito mais cerca da capa muscular para ter toda a capa da submucosa para que o patólogo possa avaliar se você há passado de 500 micras de invasão tumoral, onde o tratamento não é mais endoscópico e passa a ser quirúrgico. Quando vamos avaliar todas as publicações do tratamento, mira que não há diferença se vocês têm uma displasia de alto grado ou se tem um tumor T1A ou T1B. Tanto fazem a mucosectomia ou o ISD. Acá não estão demonstrando o que uma é superior à outra técnica. Qual é minha posição sobre a mucosectomia e o ISD no adenocarcinoma de Barrett? A mucosectomia é mais simples e rápida, pero está limitada por sua capacidade para ressecar grandes lesões em bloco. Eu tenho a ideia, firme ideia, de que se faz necessário sacar a lesão em solo bloco, ou não mais do que 2, por causa da alta taxa de recidiva locais. Então, as limitações da mucosectomia por etapas de lesões grandes incluem uma alta taxa de recorrência e uma muestra de tecido menos que ideal para uma avaliação histológica precisa. Então, isto é um conceito importante. Tem que saber se é possível sacar em uma só peça. Se é possível, faça a mucosectomia, se não tem a característica de invasão profunda. Porque o ISD, eu aplico o ISD nessa circunstância quando a ressecção em bloco, independentemente do tamanho da lesão, é necessária, e o que reduz o risco de recorrência e facilita a estadificação histológica precisa. Pero a melhor indicação, quando vamos falar, está que o ISD pode oferecer uma ressecção curativa. O ISD é diagnóstico e é terapêutico, desde que você não tenha risco de ressecção incompleta e a evolução patológica deficiente como uma mucosectomia convencional. E eu sigo o que habla a Sociedade Europeia de Endoscopia. Se tenho lesões maiores que 15 milímetros, se aquelas com características de invasão da submucosa superficial e em pacientes que têm a cicatrização, a fibrose do tratamento endoscópico quirúrgico prévio, vão impedir um levantamento suficiente com a mucosectomia, eu indico o ISD. Pero, se é possível sacar com a mucosectomia a área suspeitosa, eu prefiro fazer a mucosectomia e complementar com a radiofrequência. Graças por o tempo e por a atenção de todos vocês.
Eduardo, muchísimas gracias. Excelente presentación. Muy bien manejado el desafío. Te puse un tema incómodo porque sé que te gusta mucho el ISD y el título era medio detractor del ISD, así que la idea era esa, generar esa controversia, y lo has manejado, como siempre manejas todas las charlas y todos los contenidos de manera brillante. Creo que lo que hemos tenido en ambas charlas es el mejor update posible sobre el esófago de Barrett, y para corolario y terminar esto con el mismo nivel que empezaron las charlas, creo que con 2 o 3 preguntas muy puntuales podemos aprovechar algunos minutos más de ambos expertos. Lo voy a dejar también a Matías, que tiene un par de preguntas. Voy a empezar primero con Jacques. Una de las cosas más relevantes o más desafiantes, si se quiere, de tu charla fue el hecho de que el R1 no es una indicación necesaria de cirugía, teniendo en cuenta que el gran porcentaje de la audiencia que nos está viendo son cirujanos. El hecho de que un R1 endoscópico no sea indicación de cirugía, sin dudas es desafiante, y la pregunta mía es, ¿qué pasa con las glándulas enterradas en el follow-up de esos pacientes que fueron R1? Si uno hace el follow-up para detectar enfermedad superficial, ¿hacen ecoendoscopía en ese follow-up? ¿Hay alguna forma de detectar las glándulas enterradas? Y la otra pregunta, así ya no te interrumpimos luego, es en la displasia de bajo grado, el diagnóstico, el overdiagnosis es realmente relevante, y creo que es el game changer, ¿no? Si uno tiene bien diagnosticado la displasia de bajo grado, creo que no hay duda de la necesidad de ablación. ¿Cuáles son, en tu opinión, las características claves que el patólogo debe buscar para no hacer sobrediagnóstico de displasia de bajo grado, si es que hay un par de claves, además de lo que podamos ver en la web que mostraste, que es espectacular?
Thank you, Alex. I will try to answer the questions as brief as I can. Clues for the pathologist to avoid overdiagnosing low-grade dysplasia are the presence of extensive inflammatory abnormalities in the biopsies, feedback from the endoscopist that there was significant reflux esophagitis, and the finding of only a very small area of atypia in conjunction with these inflammatory changes. Then the pathologist should be very careful, because atypia may resemble neoplasia or dysplasia, especially in the presence of significant inflammatory changes. And as an endoscopist, you can avoid that by telling your pathologist that there were inflammatory changes. That does not mean that you should withhold biopsies for every grade A or grade B reflux esophagitis that you see. The recent guidelines suggest that you should still biopsy these patients and not reschedule them for an additional endoscopy. That's really not necessary. You just tell your pathologist, and if your pathologist then still diagnoses low-grade dysplasia, you keep the patient where he is, and you send out the biopsies for pathology review. And I think in the near future, we will have automated slide scanning and assessment by other tools that may actually replace pathology review for low-grade dysplasia. We have a lecture out at DDW that actually suggests that if you send 4 slides out to a company that does automated scanning of these slides after multi-staining with 15 fluorescent stains, that actually the assessment of that automated algorithm outperforms all expert pathologists, and is just an easier way of doing that. So the future will provide us probably with a more subjective and easier accessible histological evaluation of specimens. Do we do endoscopic ultrasound after endoscopic treatment of early neoplasia? We only do it for patients that we treat outside the guidelines. So patients with a high-risk mucosal cancer, so poorly differentiated mucosal cancer or lymphatic invasion, even though it's a mucosal cancer, are recent data actually suggests that these patients, although they still have a mucosal cancer, have a significant higher risk for lymph node metastasis comparable to submucosal cancers. So high-risk mucosal cancers and any submucosal cancer that we resect endoscopically, either with ESD or with EMR, we keep the patient under endosonographic and endoscopic follow-up every 3 months. And we do not send these patients out for esophagectomy unless they manifest lymph node disease either at baseline or during follow-up. Again, it's a prospective international study that we coordinate, so it's outside the guidelines, but I think in the future we will see that patients with, especially with the progress of ESD technology, in which we really can do a good unblock resection even of deeper invading lesions, that also an SM2 cancer or a poorly differentiated cancer, and maybe even patients with submucosal lymphatic invasion cancers undergo repeated staging 6 or 8 weeks after the ESD with endoscopic ultrasound and PET-CT scan. And if they're all negative, at least we anticipate that we will keep these patients under endosonographic and endoscopic follow-up and will not require surgery in the majority of these patients at the expense of finding a positive lymph node in a small subgroup of these patients that will then be treated with chemoradiotherapy and surgery, which may be even a more appropriate treatment than just a prophylactic esophagectomy in all these patients. Again, this is outside guidelines, but I do think the field is moving into a more wait and see policy for radically resected submucosal cancers. It's not only for the esophagus, it's also for the rectum, where this approach is gradually expanding and becoming more and more accepted.
Sí, totalmente de acuerdo, Jacques. Y bueno, sabemos que seguimos de cerca ese estudio, bien de cerca, porque siempre hemos adoptado las políticas que vienen de centros y estudios serios como AMC, así que esperamos ansiosos que se transformen en standard of care. Eduardo, uno de las slides, y ahora le abro a Matías para que complete las preguntas. Una de las slides que tú muestras, que es la más por ahí controversial, es el trabajo de Terhegen, que muestra que hay una diferencia inicial de EMR versus ESD en lo que es R0 y R1, pero que esa diferencia a los 30 días desaparece, que tiene que ver un poco con lo que Jacques hablaba en su presentación, de que no todos los R1 evolucionan mal y necesitan una esofagectomía. O sea, encuentro una unión entre las dos charlas en esa diapositiva, y mi pregunta a Eduardo, y si Jacques quiere sumarse a la respuesta, es: ¿puede tener el mapping de cuando uno saca la pieza y la pone en la plancha y la envía al patólogo? ¿Puede haber ahí un factor de error que haga un overdiagnosis del R1 en lo que es EMR versus ESD? Eduardo.
Sí, en verdad, cuando usted hace la disección o cuando usted hace la mucosectomía, tiene que tener en cuenta que muchas veces los límites de la resección tienen el efecto de la corriente de corte que usted utiliza, de coagulación, y que eso causa un daño en los tejidos. Y muchas veces el patólogo habla que usted tiene una resección incompleta. Y na verdade, quando você vai fazer o acompanhamento e vai sacar com biópsias em los sitios de resecção, não passa nada, porque não tem mais resecção. Então, muitas vezes, eu creio que isto é um erro de diagnóstico patológico. E muitas vezes, quando você tem a resecção, no momento da resecção, que você sempre tem que mirar as bordas onde ha hecho a resecção. E eu tenho o hábito de, depois de fazer a dissecção ou mesmo de la resecção, vou de novo com algum método de cromoscopia para tentar compreender se todo o aspecto que há demarcado e que há identificado se saiu na peça. E muitas vezes o compromisso de 30 dias que a mucosectomia não há diferença com a dissecção endoscópica da submucosa, tem a ver também com o comportamento biológico do tumor e tem a ver também com a corrente que é utilizado. Então, eu creio que tem dois pontos controversiais nesta questão. O primeiro ponto é a questão do patólogo, que tem um conceito equivocado, não se pode definir adequadamente porque tem o dano dos limites da restrição. E o segundo é que, por algum motivo que nós outros não compreendemos muito bem ainda, o comprometimento biológico desse tecido residual, que em geral é uma área muito pequena, se queda bem, não passa nada e se resolve o problema.
Eduardo, excelente. Jacques, ¿qué pensás? El 70% de esos pacientes que tú dices que son R1 y no necesitan esofagectomía, ¿puede ser que no sean R1 y que sea lo que dice Eduardo, de que es sobrediagnosticado por un tema de cauterización o bordes o mapeo?
Well, all this is relatively new because ESD in Barrett's has not been around for that long. A couple of things that I've learned when I've been doing ESDs now for, I think, about 10 years. And still ESD is difficult. Being totally under control for a complete ESD, especially if the ESD is for large and for bulky lesions, is, even in my hands, a pretty rare thing. So sometimes I just lose my orientation only for a short period of time, and I find that I've been partially coagulating into the specimen instead of into the adequate dissection plane. Or sometimes there's a bleeding and I have to coagulate a bleeding spot, and my coagulation also goes into the bottom of my resection. Those cases in which I truly stripped the tumor of the muscle layer, or even cut through the cancer, which sometimes happens for deep invading lesions, that's a totally different situation than a situation in which the R1 resection came back as a kind of surprise for how I finished the procedure. And it may very well be that sometimes the R1 may be an artifact of combinations of the skills of the endoscopist and his lack of orientation, especially in the final part of the resections where the specimen may rotate on itself. And this is really sometimes difficult. And some of the R1s actually may be caused by the endoscopist. Some of the R1s may be truly cutting through the cancer. And logically, we need more studies with pathologists trying, and they should be able to distinguish these two. If you have a broad-based R1 over a larger area, over multiple cuts, the likelihood of that being a true R1 with clinical consequences is totally different from a very focal area where this may happen. And bear in mind, we're only talking about the vertical R1, so the lateral margins of the lesion that you resect. We stopped bothering about that in Barrett's a long time ago when we did piecemeal resection and never attempted to place the specimens together. A Barrett segment in itself is dysplastic. So once you do your endoscopic resection, having low-grade or high-grade dysplasia at the lateral margins of the specimen really has no clinical consequences. You're going to do the RFA of those patients anyway. An important take-home message finally is, for every resection that you do, either a multiband mucosectomy or an ESD, you should place your electrocoagulation markers before you do your endoscopic resection. So you have a plan before you make your first cut. So there's never a need during your resection to adjust your plan, because you've looked at the lateral margins of the lesions under optimal circumstances before you did anything to the lesion, with NBI in nearby focus, with a small cap on your scope, you gradually delineate the lesions. And when the delineation is done, that's your resection plan. Don't change that. Don't resect outside those margins, just only resect that part. Before you do your endoscopic resection, your plan is in place, and that's what you remove either with piecemeal EMR or with ESD. If you do that, the lateral margins are really not relevant anymore. It's only the deeper margins and the high-risk features, poorly differentiation, lymphatic invasion, and really truly deep submucosal invasion. And then it becomes a matter of weighing the risk of the patient and how you can communicate with your patients to make a decision that sometimes the patient will just refuse surgery if you tell them. And some of my other patients say, well, I just want to be sure. And then we say, okay, then we'll have to take out your esophagus, because if you can't take the uncertainty of something that's outside the guideline, then you should follow the guideline and stick to an esophagectomy.
Impresionante. Matías, gracias, Jacques. Matías, preguntas para cualquiera de los dos.
Sí, yo tengo un par de preguntas y después hay algunas preguntas del público que vamos a hacer antes de terminar. Yo tengo una pregunta acerca del seguimiento. Si el grado de displasia o la presencia de adenocarcinoma les cambia el protocolo de seguimiento, y tengo entendido que hacían endoscopía de follow-up cada 3 meses con biopsias al azar, y creo que lo están dejando de hacer a eso. Mi pregunta es, ¿cuál es su opinión? Y después, esa pregunta para los dos, y para el doctor Bergman, una pregunta acerca del cryoablation balloon. Veo que los feasibility trials mostraron muy buenos resultados de regresión del Barrett con un porcentaje levemente superior de estenosis con respecto a la radiofrequencia ablation. ¿Cuál es su opinión acerca de eso también?
Entonces, a respecto que se tiene otro sitio de adenocarcinoma o de displasia de alto grado, ¿no? Entonces, o que nosotros hacemos, se tem uma área que tem outro sítio de lesão, pero a característica é que a ressecção endoscópica é curativa, eu vou fazer uma nova ressecção da lesão. Então, não vou indicar uma cirurgia se a pessoa tem uma lesão que está restrita à capa mucosa. Então, vou sacar. O que cada dia mais é possível é você estudar de uma maneira muito mais direta as lesões focales, que são o mais importante para que você faça uma biópsia dirigida ou mesmo sacar a lesão. Então, cada vez mais, acá não fazemos no protocolo de Seattle, acá fazemos milimetricamente a cromoscopia com NBI, e me gusta muito utilizar o ácido acético, que tem ajudado muitíssimo para definir os margens, os bordes, as características da área suspeitosa. E neste sentido, eu vou a ressecar a lesão e vou avaliar o primeiro ano a cada 3 meses, tomando a biópsia, igualito a primeira lesão que é sacada. Jacques?
I think the follow-up regimen is very much determined by if you do only the endoscopic resection, or if you supplement that treatment with RFA and achieve a complete conversion. If you only do the endoscopic resection and there is a significant Barrett segment left, then you should probably stick to the original follow-up regimen proposed by the Wiesbaden group. That's before the ablation era, which is every 3 months with close inspection. I think closer inspection is more important than just random biopsying, as Eduardo says. So if there's a residual Barrett's and you only resected the cancer, you better sit on that patient because he has a significant chance of recurrent disease. If you do subsequent ablation with RFA and achieve a complete ablation, complete conversion of the whole Barrett segment, then most guidelines still advise every 3 months, but we stopped doing that a long time ago in our Dutch studies. And we show that in the first year, you just find nothing. And we also stopped taking random biopsies of the neosquamous mucosa And we also stopped taking biopsies of the cardia. So we just do a very close endoscopic inspection. Every 3 months we treat a patient. Once the patient converts to the whole Barrett's is gone, we jump to 1 year, and we do 1 year intervals, only with a very close inspection with white light, high resolution endoscopy, and with MBI, and with retroflex inspection of the cardia, in which we will only obtain a biopsy if there's a slightly nodular lesion or anything that looks suspicious. Again, please bear in mind that these are centers that are highly trained and highly skilled. And discussing this with my American colleagues, when we were making new guidelines for how American endoscopists should follow up their patients, they basically said to me, Jacques, this may work in the Netherlands, but it does not fly in the United States, where endoscopists have less experience. We just want to keep all these random biopsies, even after complete conversion of the Barrett's. We still want endoscopists to obtain biopsies throughout the original Barrett segment and from the cardia. So with that disclaimer, if you're experienced and you know your work, just look longer and biopsy less. If you're not experienced and you only treated few cases, think again before you treat the next case, or become more experienced. And in the meanwhile that you become an expert, but only while you become an expert, and you better become an expert pretty well, otherwise you should simply not do these cases. In the meanwhile, you can do a very rigid follow-up. But as Eduardo said, it's the endoscopic inspection which is more important than the random biopsy. And Matías, then to get back to your cryoablation, I think you picked up something that is indeed true, that cryoballoon ablation may have a slightly higher fibrotic effect than RFA, and therefore a slightly higher stricture rate. There's no comparative studies of the two. What I found in the patients we've treated is that the esophagus looks more fibrotic after cryoballoon ablation, and it also looks more fibrotic after hybrid APC than after RFA. And in our experience, recurrent lesions after RFA, even if you've done 4 RFA sessions, recurrent lesions you can still remove without submucosal lifting with the MBM technique. That's something I'm afraid will not fly with hybrid APC and with cryoballoon ablation. And so with the reduced efficacy of an escape EMR, I think that is an underestimated potential downside of more aggressive ablation techniques.
Bárbaro, muchas gracias.
Sí, Mati, última pregunta y...
Sí, hacemos del público, ¿te parece, Ale?
Sí.
Acá preguntan, considerando que el reflujo es la única causa conocida para aparición del Barrett y su progresión, ¿cuál fue la estrategia para controlar el reflujo luego de la ablación?
Jacques, only 2 minutes to answer that.
Shall I start? We in the Netherlands, we treat our patients with a double dose PPI, and if they, under that dosage, if they with RFA convert to squamous mucosa, they are really adequately treated with a PPI, and then we don't see any need for prophylactic fundoplication. Rare exceptions are young patients, less than 50 years of age, who have poorly controlled reflux disease, and then the indications are basically the same as for any poorly controlled reflux patients. Then a Nissen fundoplication is a logical thing. So only for very young patients, that's about 5% of the early cancers we treat, and generally only for poorly controlled reflux disease. In a country where Nissen fundoplication is not the dominant treatment strategy for reflux disease, I might add.
Eduardo, ¿ustedes qué hacen?
En nuestra institución, que es una institución que tiene las personas que tratan de Barrett, estão mucho más ligadas a los cirujanos que a los gastroenterólogos. Acá tiene la idea de hacemos la resección endoscópica, hacemos la radiofrecuencia y de 30 días después, si es una persona que tiene una buena condición clínica, se não é uma pessoa que tem muita comorbidade, em geral, estes pacientes são submetidos à cirurgia onde hace la funduplicatura, porque tiene o conceito que quando você utiliza solamente o inibidor de bomba protónica, quando se usa o PPI, não é suficiente porque tiene mucho reflujo alcalino. Entonces, en este sentido, la funduplicatura tiene un concepto muy, yo reconozco que es muy controverso, de que se puede proteger un poquito más do que solamente la doble dose de lo PPI. Y también las personas que nosotros tratamos acá tienen una condición social muy baja y que muchas veces, si no recibe el medicamento, no tiene condición de también adquirirlo, ¿no? Entonces, tiene un peso social y también un racional un poco distinto do que se hace en la Europa.
Muy bien. Bueno, nosotros lo que hacemos es estudiar, luego del tratamiento del RFA, hacer control del reflujo estricto con IBP y sucralfato y monitoreo de pH impedancio para tratar de ubicar a esos pacientes que tienen escapes biliares o alcalinos y a esos indicarles funduplicatura, que creo que es un poco caer en el medio. Seguramente hacemos más funduplicaturas que en Ámsterdam y probablemente alguna menos que en San Pablo, pero creo que es un rango que hay que ir manejando de acuerdo a la realidad de cada centro y de cada sociedad, como bien marca Eduardo. Podría charlar todo el día con ustedes, además de grandes científicos, son grandes amigos. Creo que la gente ha disfrutado muchísimo de este webinar, pero tienen que volver a sus trabajos. Jacques seguro que tiene la cena lista, porque en Europa son las 6:30, y Eduardo debes tener tus pacientes de la tarde, así que les agradecemos muchísimo, muchísimo, muchísimo haber estado presentes y espero que el público lo haya disfrutado tanto como lo disfrutamos nosotros. Así que con esto los despedimos. Gracias, Matías, por estar también online, y a toda la Comisión de Endoscopía y a la Asociación Argentina de Cirugía por hacer esto posible.
Gracias a ustedes. Gracias, doctor de Moura y Bergman. Sandra, no sé si quería hacer el cierre final.
Bueno, Mati, gracias. Nada más que agradecerles a nuestros invitados muy especialmente. Realmente un placer, excelentes conferencias. Agradecer a nuestras secretarias, a nuestras traductoras, a la Asociación de Cirugía, a toda la Comisión de Endoscopía Flexible y a todos los que compartieron con nosotros esta actividad del otro lado de la pantalla. Nos vemos el mes que viene, así que muchísimas gracias y buenas tardes.
Luego.